Hi, Dr. Kam Lally here, cosmetic physician. I've been practicing in the Midlands and in London for around about 10 years. Very excited to present this episode of Injections Made Perfect, and what it will cover is my origin story in the world of aesthetics, and then a wonderful holistic demonstration in a really lovely patient.
So I'm Jeremy Isaac. I've got nearly 2 decades worth of experience. I know looking at me, you could hardly imagine that. I started when I was about 1, but this episode of Injections Made Perfect with Dr. Lally and myself will show you and demonstrate to you how you can take our patient through all of the treatment protocols safely and efficiently using the top products, using TSK and toxin, and create an outcome that is still natural and still harmonious. We will not be exaggerating her, and we will be accentuating her and bringing what she sees outwardly to match how she feels inwardly. I hope you enjoy this video. We've had a lot of fun making it.
Hi, my name is Dr. Kam Lally. I'm a GP by trade and training, and I'm also a cosmetic physician based in the Midlands and London in the United Kingdom.
Hello, my name is Jeremy Isaac. I am a dental surgeon by background and a cosmetic practitioner. I have practices in South Wales and a satellite practice in the West End.
So what got me into aesthetics? When I finished my GP training pretty much a decade ago, I wanted a little bit more variety in what I did. And actually, I was a little bit restless. So I often use the acronym ADHD as to what sort of got me into the world of aesthetics. And if I expand upon that, Jeremy's laughing at me. So A is with regards to the autonomy. I wanted to have an element of autonomy in my work, because the NHS I found quite restrictive and constrictive. And then with regards to the D, it was design. I wanted to do something that was artistic and creative. And again, I felt that I couldn't really have any artistic outflow with regards to my NHS work. Therefore, again, aesthetics was the perfect fit. The H stands for humanity. I'm still a medic at heart, and my calling is still to help people. And I wanted to make sure that I could do something that would give them a real positive impact, physically and mentally. And then the final D is for dexterity. I wanted to work with my hands, and I realized that the creative element was actually to do with creating something and sculpting something, and therefore I wanted something that involved manual dexterity, and that all pointed to the world of aesthetics.
It's a great answer.
How about yourself, Jeremy?
So my inspiration comes from when I was practically a child. As a Max Fax graduate, I went into surgery seeing people who were surviving from trauma, from cancer, and what we could do to those people, how we could turn their lives around, give them more confidence, enable them to go out in the wide world, was transformational for me. So I was inspired by that. And then when I went into private practice, I felt that these small changes that could be made to patients' appearance by enhancing certain things that they've had as insecurities for all their lives would greatly increase and improve their psychological states. So for me, the inspiration, and I've been doing this for around about nearly 2 decades now, I was an early adopter, has been the way that you can transform patients' confidence with the smallest tweaks to make them look natural and improve their outward appearance.
Wow, maybe mine was slick, but that was deep. That got me in the feels.
Well, ADHD, man. I'm going to talk about my OCD in a minute.
Oh dear. No, that's really inspiring, and I think quite touching. How you've taken sort of your inspiration from your NHS work effectively with trauma victims, and translated that into aesthetic practice and made it more accessible.
It's made phenomenal differences to patients' lives.
When it comes to inspiration in the aesthetic world, for me, there have been so many friends and mentors who, over the years, I've thought just, wow, how do you do what you do and how do you present it? And the way they break down the constituent parts that make up, for example, negative expressions or that show the signs of aging. And then when they treat them individually, the sum of the treatment is greater than the parts. And you get this real wow result. And for that, I've learned so much of so many people, and I found them inspirational, not only in their technical skill, but also actually in their stage presence, in their delivery of how to actually teach. Because I find inspiring teachers people to look up to, and that has been an important factor for me. I don't know about yourself, Jeremy. Is there anyone in particular, or was there a shift in the industry that really caught you?
So for me, the inspiration, and I've been inspired by, when I started a long time ago, everything was eminence-based, and we would hang on every word that the KOLs were talking about, but they couldn't back this up with any evidence of what they were saying. In recent years, there's been a huge shift in the aesthetic world, and we're now relying on more evidence-based medicine to justify techniques, products, placement of that products, the tissue and the rheology of the products are all now being looked at and written up, and scientific papers have been published on these subjects. And my inspiration has been that, being a little bit geeky, I like to look at the evidence before I want to do something with the procedure. And now I can go and source that from many publications and find legitimate evidence to inspire me to use that specific technique. So my inspiration has been a little bit more scientific, although I've seen some great presenters, as you say, Kam, and had some great mentors. My inspiration has been, now I can actually say, this is the right way to do it, because I've come from a background of surgery where I knew for many years what I was being taught wasn't what actually was under those layers of skin. And so now I know what's under those layers of skin, and it's been written up, and the approach, the aesthetic approach to treating those layers of skin has now been identified. So for me, it's science.
That's brilliant. There's one thing I really completely disagree with what you said when you're saying that you're a little bit geeky. I think you're a little bit more than a little bit geeky. So
says the man with OCD and ADHD.
Hey, I use it to my advantage. My patients love me for it. You know, it's the curse of being a perfectionist. Do I have a set idea or philosophy about what beauty is? I really, really don't. And I think what the most important thing here for me is actually you can't have rigid patterns and ratios and things, because beauty it's truly in the eye of the beholder. So actually you need to know what the person that you're treating feels is beautiful, and that needs to fit into their ethnic, social, cultural context. But essentially, what will enable that patient to leave your clinic feeling happier and making sure that if there's any discord between what they see in the mirror and what they feel inside has been alleviated, then you've done your job. I think once people are actually confident in themselves, then they feel beautiful. And I cannot, honestly, I don't think there is one definition of beauty. And I would disagree with most people that argue that there is. You can have mathematical ratios, and I get that. And I get that the artists used to use them to recreate art and things like symmetry. And I'm sure Jeremy's going to rattle off a few categories that contribute to beauty. But me, as the philosopher, I really don't think that there can be one set ideal of beauty. And you can even have a set of twins, right? And if they come into you, they could have completely different viewpoints of beauty. And your job as their practitioner and as a medical expert is to ensure that you align yourselves with what their ideal of beauty is. However, there's always a caveat. Because of things like social media, filters, and this celebrity culture, whereby they may be masking any treatments they have had, sometimes the idea of beauty in younger patients can be a little bit skewed. So I believe that we've got an ethical and a moral obligation here to ensure that we try to guide our patients and ensure that they don't become looking overtreated or overfilled. I think that was a long-winded answer for me to basically saying, no, there isn't an ideal of beauty. What are your thoughts, Jeremy?
No, I agree. I don't think people can be categorized by phi or Fibonacci or, just mathematical equations. I think the ideal of beauty is, as you say, in the eye of the beholder. And we as practitioners want to accentuate the person's natural beauty and not exaggerate to become looking abnormal. But we can talk about the 4 concepts of beauty when we talk about ideals of concept of beauty. And they include symmetry, averageness, youthfulness, and gender dimorphism. And we get patients coming in all the time, I feel, that just want symmetrical look. But is symmetry as important as all of that? And we know that even from embryological development, that the 2 halves of the face do not develop as equal halves. We get one side that's higher, rounder, and more attractive, and the other half that's lower, longer, and less attractive. And when we teach people and we put those symmetrical pictures up of Kim Kardashian or whoever else it might be, the audience always selects the asymmetrical Kim Kardashian. They never select the right-sided or the left-sided. So for me, the ideal of beauty is the way things fit together in harmony, balance, and proportion. And if we can get those 3 things right, then symmetry is not so important. Averageness needs to be considered in the ethnicity or the age of the patient. Youthfulness, everyone wants to look younger, but what is it that makes us look younger? How does the light reflect off our face? If it's reflecting evenly, it gives the illusion of being younger. And then gender dimorphism. We need our males to look like males, our females to look like females. And if we have transgender patients, then we need to know how we're going to take those patients on the journey that they're choosing to embark. So we need to have specific treatment protocols for male, for female, for younger, for older patients. And none of those can fit into a ratio. That's my view on that.
Yeah, I agree. I think so. I think very eloquently put. My treatment philosophy, in a nutshell, is less is more. And initially, this actually started off as a necessity, being based in the Midlands and not in a necessarily affluent area such as London. Before having opened a clinic location in London, I knew that I had to maximize my results with actually slightly more modest quantities of product. So I very much learned how to maximize what I could get per syringe and actually maximize the patient's budget. And how that's evolved is with how the market has changed, whereby we are seeing people who are overtreated, looking unnatural, looking overfilled, and almost giving the aesthetic industry and aesthetic medicine a bad name. So that philosophy of less is more has now firmly sort of concreted itself with me, my brand alignment, and with my treatment. So every time I see a patient, I'm thinking, what can I do with the minimum amount of product? And that's actually now more to achieve natural results, to ensure that the treatments that have been done are barely there. I don't want the patient's friends, family, etc. to know exactly what they've had done. I just want them to look rested and rejuvenated. And that's another core part of my philosophy. I think sometimes patients want enhancement of certain features. However, in some cases, refreshment and rejuvenation is a better overall goal because it brings their face into harmony from a global perspective.
That's a great answer.
Thanks.
So, and I agree with everything that Kam says. I also come from an area that is not an affluent area, and price point is significant. So the more you can do with the least amount of product, the better the outcome for that patient. So if I can get an accentuation rather than an exaggeration, a natural look to my patients with a minimum amount of product, then that satisfies me. It gives them the outcome they want, but it's also at a price point that they can manage. So for my patients, I take them on a journey. I suggest we're going to go on a train trip from South Wales, and it usually ends up in Paddington, but we're going to stop along the way And every 3 weeks, they're going to assess whether they like where they've stopped. And if they like where they've stopped, then they stick. And if they don't like where they've stopped, they have to move to the next station. But what that gives my patients is the ability to choose for themselves whether they've gone far enough. Because far too often, as we know, patients are coming back overfilled. And for some patients, it might take 3 weeks to a month before the product is really settled in their face.
And integrated.
So if we get 100% correction on the day, when we review them in 3 weeks, 4 weeks, we are then going to have an overfilled patient coming back. So what we should be doing is taking smaller steps with our patients and encouraging them to come back and getting on a journey, an adventure together, and seeing if they like some of the stops. And if they like some of the stops, then they've got enough product, because it's so easy to put too much product into patients now and create this overfilled and natural look that everyone now is coming back and is being dissolved because they've had the wrong product placed in the wrong tissue plane. Instead of having in the wrong quantities, instead of having a dynamic product put in a dynamic plane and a static product put in a static plane, we've got products put in incorrect planes with the incorrect rheology. The consequence of that is we get abnormal appearances.
And I think filler science has progressed so much that fillers are lasting a lot longer than we thought they were initially. So you're getting this cumulative effect where actually filler is starting to sit on filler, and you're actually creating this platform or iceberg, and that's only going to create problems further down the line.
And we see the way people have been taught that they put deep to bone, deep to bone, deep to bone, and that's all they put. And then to get the outcome, they have to put more product, and that more product creates more swelling. Whereas if you use the toxin approach, the multi-layering, where you can put product closer to the surface because it's a dynamic product, as you can put in a dynamic superficial fat, you can use less product. And we know that we lose 18% of the deep fat and 11% of the superficial fat. As a consequence of that, you have to multi-layer to get a natural appearance. So techniques have changed dramatically. Products have to catch up a little bit. We have to mimic natural HA more and not have this highly cross-linked static product, because it limits the places you can put it in, and I don't think it gives natural outcomes.
Well, got him on soapbox, huh?
Sorry.
That's all right.
That is my thing.
Funny thing you mentioned about techniques. When I actually got into the industry, I remember there were two distinct camps. There was, are you a needle person or are you a cannula person? Like, looking back now, that seems ridiculous, right? But I say I'm pretty much firmly in the cannula camp. You know, 90% plus of my treatments are done with a cannula. But I just think the appreciation of safety as and that evidence-based safety has been a huge shift forward in how if we see aesthetic treatments. It was like we didn't know what we didn't know, and ignorance was bliss at the time. But now the field is expanding. A lot of it's more evidence-based. And we're finding more and more that's actually guiding our treatment philosophies and treatment protocols.
And the advent of the use of ultrasound in aesthetics has just been transformational. Now we can actually see where we're putting the product. We can see where the risk is. And instead of surmising that the risk is deep or the risk is superficial, depending on the area of the face, trying to assess 3 dimensions or 2 dimensions, we can now physically look at it by using ultrasound and be more specific where we place in away from the risk.
And I mean, again, that aligns with our philosophy of creating something bespoke. What's more bespoke than having your facial anatomy checked with an ultrasound, and then we put the right product in the right plane according to safety as well as the results, and in the right quantities. Perfect.
We all look different.
We do.
If we all look different, there must be a combination of the components in our face, because we've all got the same components. But if we all look different, there must be a different size, different shape, different dimensions, different stages of aging of those componentry. And to imagine that we know where those vessels run, they cannot be the same in your face and my face. Because if I look different, the vessels run between and up and above and below that componentry, which is then going to make those vessels in my face and your face unpredictable. What you've got and I've got will not be the same. Even, facial artery, the angular artery, may not even exist past the alar
Yeah, that's
or even lower down. So the vascularity of the face is completely unreliable, but with an ultrasound, we can see exactly where it is.
Yeah, so I guess to summarize, it's less is more, safety, 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 and then keep the result natural. We're very excited to present to you a holistic demonstration of how to globally harmonize the face in our wonderful model, who is 47-year-old Millie, a dentist from London of Greek origin. And what she was finding that when she looked in the mirror, there was a mismatch between what she felt like inside, which was young and full of energy, compared to what she saw in the mirror, which was tired and aging. So what's the plan, Jeremy? What are we going to do?
We are going to look at the thirds. We're going to look at upper third, middle third, and lower third, and assess whether any of Millie's depletion and any of the things that Millie is seeing in the mirror, we can enhance upon. So we will be looking at the individual subunits of the face, seeing where any signs of aging are, and seeing how we can help her renew and refresh her outward appearance to match the way she feels inwardly.
Now I'd like to introduce you to our wonderful patient, Millie. She's 47, of Greek descent, but living in London. Millie, would you like to tell us a little bit about what brought you in to have treatment today, please?
I see myself every day in the mirror, and as I grow up, before I start my day, seeing my face in the mirror is a little bit saggy. And I feel this mismatch between the appearance of my face and how I feel to start my day.
Perfect. Thank you very much for that, Millie. Millie is an ideal patient for treatment. With a few select treatments in certain areas, will significantly refresh and rejuvenate her face, which will then enable us to make her outward appearance match how she feels on the inside. And rather than focusing on a single area of anatomy and enhancing or over-enhancing that, doing a global rejuvenation also sits well with my personal philosophy of treatments, which is less is more. Let's take a closer look at Millie's face. When we are doing a global assessment of the harmony of Millie's face, what we can see is generally she has excellent skin, which is a great characteristic to work with. However, when we look at her, we can see some areas of shadowing, predominantly around the eyes. We can see shadowing around both eyes, and then if we follow that through, we've got some shadowing around the nose and then around the corners of the mouth. The other thing when doing global assessment that we will see is if we were to split the face into two halves, there is a bit of asymmetry between the two halves, and this is quite common. What we can see on Millie's right side is that her hairline is slightly higher on one side, the brow sits slightly higher, as does the cheek apex, and also what Millie spoke about with regards to the sagging of the tissues. The jowling on her right side is less so compared to the left side. If we take a slightly more detailed look into Millie's proportions using the classical canons used in beauty, if we divide the face up into thirds, so the upper third, which runs from the trichon to the nasion, and then we have the mid third, which runs from the nasion to the subnasale, and then from the subnasale to the menton for the bottom third. The thirds are quite evenly matched and proportioned, and if we were being picky, we'd say that the mid third is slightly compact compared to the other thirds. Then if we look at the vertical fifths of the face, again, Millie is quite well balanced when it comes to the vertical fifths. And looking at the mid fifth, which is usually in line with the intracanthal distance, going to the lower aspect of the face, one could argue that her chin is sitting slightly outside of the mid fifth, and we could improve that by bringing the majority of the volume centrally.
Now, after that static assessment, I'd like to look at Millie in a more dynamic way. Because as we know, the face is not just static. The face has dynamism. And if we don't replicate dynamism when we are augmenting her face, we end up with an unnatural look. So Millie, if you could look at the camera and blow us a kiss. Thank you. Now smile. Now relax the smile and frown at me. And now lift your forehead up. Thank you. So now you can see that there's a dynamic aspect of facial expression that we have to mimic during our treatment protocols. So when we come to augment, we'll be looking for dynamic products that we can place to enable us to naturally enhance Milly's face. We can see the upper third has a boundary. The upper third starts at the hairline and ends at the nasion. The upper third contains two aesthetic subunits, the forehead and the temple. The extent of the forehead, you can see just some light reflectivity here on the superior temporal crest. That is the extent of the forehead. It goes from the tracheon to the nasion, and then from the superior temporal septum to superior temporal septum. That is the extent of the aesthetic forehead. Then you have, in the same upper third, you have the temple, and the temple goes from the superior temporal septum down to the superior border of the zygoma. It extends back to the hairline, and it comes forward to the orbital rim. So the upper third contains these two aesthetic subunits, and when we assess them individually, you can see that in Milly's forehead, there's a depression, and an ideal feminine forehead has a 12-degree dome. And you can see here that there's some depletion in the lower third of Milly's forehead. And this is something that during our treatment, we'll be targeting to enhance. When we also look in profile here, you can see that there's a slight depression. So the confluence that goes from the forehead to the mid-face is disrupted by a slight concavity in Milly's temple. So that concludes my assessment of Milly's upper third.
Milly is now prepared and ready to have her neurotoxin treatment. The skin has been cleaned with antiseptic, and what we will do now is have a look at the forehead anatomy before we actually go on to inject it. And I'll hand over to Jeremy to give us a recap of this.
Okay, thanks, Kam. So the aesthetic subunit of the forehead has a lateral extent. It extends to this superior temporal crest. It has it on both sides, and the easiest way to find that is to draw a vertical line from the lateral canthocep, and you'll feel a prominence in the skull, and then that tapers backwards, and so that is the lateral extent of the forehead. The superior extent, as we spoke about earlier, is the hairline, and the inferior is the orbits, not the eyebrows. When it comes to the muscle, we know this at a specific depth. It's a two-dimensional muscle. The frontalis is a part of an occipitofrontalis muscle, and we're dealing with this two-dimensional muscle on the forehead. We can classify that muscle into four different patterns according to the way the lines and wrinkles are created. That actually allows us to then be able to determine the shape of this muscle. So, when we compress Milly's forehead, you can see that the lines go horizontally across. Horizontal lines would mean that this is a class 1 frontalis. If there was a gull shape where there's no movement in this medial portion, putting toxin in this medial portion will not have any effect on the muscle, and the muscle is a class 2 and divided in the midline, and the depth of that varies. But what we know is that 100% of the time there is frontalis low, and 0% of the time at 4 centimeters above the orbit in the midline there is no frontalis. Class 3 would be where the lines are contained in the middle, and class 4 would be where you get small lines around and above just the brow. This is really important when we assess frontalis, because if we can't determine what the classification of the muscle is, we cannot inject accurately. And this is why we're seeing lots of people with this frontal brow ptosis, where they've over-injected this middle portion, they've crashed the middle of the forehead, and the result of that is it gives the patients an angry look. What we're intending to do, because frontalis is the only elevator of the forehead, we are intending to give some lift from frontalis to open Milly's eyes. We can also assess, because frontalis has two parts, it has an elevator part, but here there may be a depressor part. So if the patient elevates and the hairline comes down, we need to put some high injection points to stop the depression that will come from the upper part of frontalis. It's at a depth of about 1.8 to about 3.5 millimeters, so it's superficial, and it's a two-dimensional muscle. So it doesn't engage into bone, it engages into the muscles that you're going to find around the eye and then into the galea superficially.
So just before I inject the forehead and rejuvenate that area, we are determining the vessel position and the vessel depth. Jeremy, if you just talk us through what we're seeing here on the screen with your handheld ultrasound scan.
So I'm using Claris L20 here, and we're trying to identify the depth in the forehead, and you can see the two bright white lines. One is the skin, and the inferior one is the bone, and you can see in that left-hand corner there's a flashing red light, which was showing the supratrochlear vessel in the mid-plane. So when Kam now injects into the forehead, we know that the vessel will be mid-plane. So if he's deep, then he's going to be in a lower risk area. There you go. Just flash in there.
So because the probe is parallel to the vessel, you will see the flash going from one side to the other.
And you can see where the hyperechoic bone is, and the vessel's not on the bone at this point, even though we are taught that the vessels are deep in this section. You can see here, but the vessel is not deep at all. It's mid-plane, and we are really quite close to the brow at this point. So within that 2 centimeter apparent safety zone, we've got the vessel mid-plane. So we need to be conscious of that when we're injecting people.
Okay, so great. So we're aware of where the supratrochlear artery is. Now we will try to get a visualization of the supraorbital artery to finish off the second of the relative danger zones in this area before I inject.
And there it is.
And here, because we've gone perpendicular or transverse across the vessel, it just appears as a dot right in the center of the screen. Hopefully you can see that.
There it is.
And Jeremy, tell us which plane it is now.
So again, it's mid-plane, because you can see, even though I haven't got a sharp line, which I'll get in a minute, for the bone inferiorly, you can see it's already nowhere near the bone. The bone is going to be at the bottom here. I'm just struggling to get the right plane because I'm running out of gel a bit. There it is. So you can see if that's the hyperechoic bone, we know that vessel is now again mid-plane. So both of these vessels, and if you look where I am, I'm right on her eyebrow, but both of the vessels are in the mid-plane, which is not going to be where the eminence would suggest that those vessels will be found. So we've got vessels here which, even though we are taught that there's a deep and a superficial zone where the vessels are in the forehead, we already know that maybe we've only got 4 millimeters of depth between the skin and the bone, and those vessels are running at about 2 millimeters from the skin and from the bone. So they're in this intermediate plane, which is neither deep or superficial. And I think this is why very often we run into difficulties, and the risk and the complications in the forehead are very high, third highest causes of blindness. And that's because I don't think we really appreciate that there's no deep and there's no superficial in this area. It is all very compact and a very narrow space into which to inject. But Kam today will be going deep, and he'll be below these vessels under the galea and consequently in the lower risk area.
Let's have another look at Milly's specific anatomy before we do the markings, and then discuss the technique and the products that we'll be using in this area. So Milly, if you could raise your eyebrows as strongly as you could for us. So Milly has previously had toxin, so she's got a slightly reduced movement. If I exaggerate her movements, you'll be able to see that this is the type 1 or the class 1 frontalis, whereby she has got the lines going all across the breadth of the forehead. So now what I will do is draw on my injection sites before we actually discuss what we're using to inject and how we're going to do that. Millie, if you could raise your eyebrows for us. Thank you. So what we are looking at is the areas where the frontalis corrugates and it's the most active. And I will be using the on-label indication for neurotoxin with 4 points across the most active part of the frontalis. I'll just get her to do the elevation again, just to see if she needs that central dose as well. Please elevate again. So we can see that she does just get a little line in the middle, so it's worthwhile us injecting that and giving her 5 boluses across the frontalis.
It's really important you don't go too low with that or overdose this area for the reason I said, because that will drop the medial brow and she'll end up looking a little bit spocked.
So I've pre-prepared my neurotoxin, and what we're using is the invisible needle here. So this is the thinnest needle that you can get on the market, and it's 9 millimeters in length. Essentially, it makes injecting almost painless for the patient, and it minimizes any tissue trauma and subsequent bleeding and potential for bruising that happens. And also from a user's perspective, it's very comfortable to use with a minimal extrusion force that would be applied. So we don't inject through our markings, therefore I'll just be injecting parallel to them, and I'll make sure I sterilize the skin beforehand with Jeremy prepared just in case we do get a little bit of bleeding or oozing. Just a reminder that the motor end plates are on the inferior surface of frontalis, so you will see me going through the muscle and at a depth that essentially helps the toxin get to the end plates more efficiently. So small scratch coming out. Perfect, we're in. So I'm delivering 2.5 units of this neurotoxin into the frontalis, onto the underside or the inferior aspect. And as you can see, it is relatively atraumatic with hardly any signs of me being there. And I'm entering a slight angle so that I ensure my needle goes to the underside of the skin marking, and you'll see the small bleb being raised there. Perfect. And there are our 5 injections done. And Jeremy, if you just give that a dab. Millie, did you feel that hardly at all, being honest with us?
I didn't feel at all, if I'm honest.
We are now going to treat Millie's frown area or glabella with neurotoxin to try and reduce that corrugation and that movement. But before we do, here's Jeremy with the anatomy recap.
So, for you guys, the learning outcome in this section is going to be how to get into the belly of these muscles. Because what we have in this section is 3-dimensional muscles. Unlike the forehead, which is a 2-dimensional muscle in one sheet, we have 3-dimensional muscles here that go from bone to skin. We've got a pair of procerus muscles that engage into the forehead of the skin forehead. They're longer in females than they are in males, but it's a bifid muscle going from the nose to the skin. Corrugator supercilii is a similar 3-dimensional muscle which goes from the bone to the skin. But what we know about that from the evidence is the greatest muscle bulk is at that medial canthal line. So injections at mid-depth here, at around about 4 or 5 millimeters deep, are going to get the needle directly into the body of that muscle. The motor end plates here for procerus sit on close to the nose. Also, the medial motor end plate of the corrugator muscle sits close to the nose, but there's also one here at the lateral tail. The danger with chasing this lateral tail is that you can get close if you go too deep, you're going to potentially interfere with the levator palpebral superioris and get a droop in the eyebrow. You're going to get eyelid ptosis. So my advice is you have to be really superficial at the lateral border, but you need to be mid-plane when you're going to take on the greatest muscle bulk at that medial canthal line. So Kam, take over and inject Millie's face.
Okay, Perfect. Before I inject, I'll get Millie to animate again to exaggerate the areas of movement so we can demarcate where our injection sites will be. Please, Millie, frown for us, as grumpy as you can get. So as you may be able to see that there is slightly reduced movement, but I can just exaggerate it to highlight where the muscle bulk would be. So relax for us, please, Millie. And now, grumpy face again, please, frown. So we can see the skin insertion of the tail of the corrugator there. Okay, we can see the muscle bulk forming of the head of the corrugator there, and then we've got the procerus bunching up centrally there, and this is mirrored on the other side. Relax, please, and then if you frown again, really grumpy frown, there we go, there's a skin insertion of the tail of the corrugator. So we've got our 5 injection sites there.
The dangers here are that you place these spots too superiorly, and if you're placing them too superiorly, we know that these muscles are engaging into frontalis, and as we said earlier, this muscle is the elevator and you want this to work, but if you're too high with these points, you'll end up hitting frontalis and not corrugator and end up crashing the brow again. So this section is critical that you make the marks specifically and then inject at an angle to ensure that you don't end up going superiorly. So that for me, my injection point, I don't know what you can, but for me, I would inject this perpendicular, so I know where the end of my needle is. So when you're trying this, if you're coming in at an angle of say 30 degrees, which is often spoken about, I don't think I know where the end of that needle is. But if I come in at 90 degrees, I always know where the end of the needle is. It's directly beneath my thumb. So try that at home, because I think that's the tip of the day for corrugator.
Okay, perfect. I will again do the skin preparation, and then we will get to inject, because we don't want to inject through our skin markings. I will start with the procerus and I'll work outwards. Jeremy, was there anything you wanted to add?
Just so that you know, we've pre-prepared the skin completely with Clinicept. So it's all been cleansed before. I know it looks like we're not really cleaning it, but we've done a thorough cleanse before we start. And Millie hasn't got any makeup on anyway.
Okay, Millie, just frown for us again, please, to highlight. Okay, and relax. So generally we will inject through a relaxed muscle because it hurts more if it's gone through a contracted muscle. So I will just inject into the procerus, the center of the procerus, pinch, lift. And there we are deep in the belly of the muscle. And again, just a reminder, we are using the invisible needle here, which is 9 millimeters long, thinnest needle on the market, makes injection almost painless and relatively atraumatic, and also very user-friendly for the injector. Frown again for us, please. Relax. So this is the head of the corrugator. Just as Jeremy says, we go into the belly of the muscle at 90 degrees, and then we inject.
So half depth here, and for procerus is full depth because we're getting to, we want to get to the origin of procerus.
Okay, and then just for the tail, very, very important that we remember that it's a skin insertion, so we want to just raise a bleb underneath the skin. Frown for us, please. Thank you, and relax.
So if you look at Kam's approach now, he's super flat. And so you will raise a bleb.
That's it. Perfect, and hopefully you can just see that very tiny amount of blanching directly under my marking. Hey, hope you're enjoying the video so far. If you want to take your skill set to the next level, we have a training program that Jeremy and I run called The Knowledge. This is evidence-based theory put into practice, because as much as you watch the videos, the hands-on training and the actual experience is what will elevate you from an intermediate practitioner to being the best. I also offer individual mentorship under aestheticology. And then we also have Jeremy offering a training program under Jeremy Isaac Academy.
Experience the hands-on, experience finding out what it feels like to get the cannulas under the tissue planes. This is where the learning begins. Watching this video hopefully will inspire you to reflect on your own practices. Come and see us and learn more advanced techniques on how to multi-layer and how to present the right product in the right tissue plane to get the right outcome for your patients.
we're now going to treat the periorbital area, or the commonly known as crow's feet area, with neurotoxin to address those pesky lines.
Just to recap the anatomy here, orbicularis oculi is the shape of an aviator glasses. It's much bigger than we think. It's a sphincter muscle, and it's the most active muscle of the face. We know that the definition of the tear trough is related to this orbicularis oculi muscle, and that the palpebral part and the orbital part where they join is the definition of the tear trough ligament. It spreads down onto the cheek and contributes to elevation of the cheek. It drops this lateral brow and also has the ability to bring the lateral brow in. So sometimes when you see the patient is moving just out here, it's because you haven't deactivated this lateral brow. It also contracts the skin here. It has 2 motor end plates, one here laterally and one here medially.
Millie, can you just smile for us, please, just to show us these lines? There we go, perfect. And relax. Because the extent of Millie's radial lines is actually quite lateral, I'm happy to inject pointing towards the eye. So this can sometimes be a little bit scary for certain practitioners. However, injecting slowly and superficially in the right plane ensures that you don't cause excess spread, and you can always pop a thumb or a finger over the lateral canthus if you want, for an added layer of protection. Or if you do not feel comfortable doing that way, then actually it's easier to inject the opposite eye from this side of the couch, and you're then injecting away from the eye, however you feel comfortable. Any thoughts, Jeremy?
I agree with that. I think you can inject away from the eye by tilting the head and being on the opposite side. I think the dangers here are the lacrimal gland up high here, and the complication of a dry eye. So superficial with low extrusion force. Low extrusion force is really important when you're injecting, because you reduce the spread of the product. If you're going to inject hard and fast, you're going to get further spread of that product. So slow blebs that are located in the area you want is the way that you're going to minimize complications. So another learning outcome here, inject slow with slow extrusion force to prevent spread. Keep the product where you want the product to work.
And remember, the TSK invisible needle helps with reducing your extrusion force because of its construction. So I'm just going to draw my markings out for the 3 injection sites in this lateral aspect of orbicularis oculi. Can you just give us a big smile, please, Millie? Thank you very much. So we can see the concertinaing of the skin. And relax, please. So it very nicely demarcates where our injection sites need to be. There is some vasculature which hopefully shows up on screen that we do need to avoid. So generally with neurotoxin, we don't overly concern ourselves with true danger zones. However, no patient likes to leave with a bruise or significant bleeding. And what will help with this is using the right bit of kit. So I turn to the invisible needle, which minimizes trauma and is more comfortable for the patient. And without further ado, we'll do the treatment. I sterilize the skin beforehand, and we never directly inject into our markings. So small pinch coming up, and the muscle is relatively thin and also just underneath the skin. Therefore, we are going in at a relatively shallow angle, avoiding any vasculature and raising small blebs under the skin. That's our 3 injection sites completed. We're now going to treat the forehead depression in Millie's head, and the way we will do this is using a cannula technique. In a moment, I will draw out what shows me where my entry points will be and the actual area for treatment. The reason we're opting for a cannula in this instance is because of safety, and specifically we're using a TSK Steroglide cannula. The length that I will use is a 50mm cannula, and I will use a 25 gauge cannula. Why do I use the TSK Steroglide cannula? There's a number of reasons actually. Firstly, it does glide very smoothly due to some proprietary technology that they put into place when they manufacture it. Secondly, it's dome tipped, and I find that actually glides through tissues relatively painlessly. The bevel is actually a smooth bevel the way it's been machined, therefore it's less likely to snag on any tissues going through. And finally, the bevel itself is very near the tip, so your tip position almost dictates the exact same position of where you deposit your product, which often differs with other manufacturers of cannulas. Let's mark out the areas that we're going to treat now. So first we palpate the temporal crest, and then we will just mark out the edge of it. So our entry point for the cannula will be just medial to the temporal crest, and the area that we're aiming to fill is this area here, where you can see the forehead depression or concavity, just to restore the convexity which is associated with youth and more of a feminine face. What we do need to be careful of, there is often a superficial vessel near the area that we want to make our entry point for the cannula, therefore just adjust your position accordingly. So I'll just re-sterilize the area. We're using RHA2 as the filler made by Toxin, and this is because the characteristics of the filler will allow for adequate elevation and revolumization, but it's malleable and moldable enough for us to manipulate it to ensure that it fits the concavity perfectly. Right.
So you can see here from the light reflectivity that Millie's got two reflective areas here, and then there's a depression, and then there's some frontal bossing. So the area that Kam has marked out is in this valley. He's just going to make the entry port down to bone, because this injection needs to be deep.
Okay, so I just contacted the periosteum, yep, and if you remove the trocar for me, just a reminder, we're using a 25 gauge 50 mil Steroglide, TSK Steroglide cannula, and what we are doing is lifting up and pinching the tissues as best we can to ensure we're on the periosteum, because Jeremy, remind us of the danger zones in this area.
So the danger zones here would be the supraorbital, supratrochlear. We also don't want to forget that there's the paracentral and the central artery running in the forehead. So it's not just those two vessels that run from the orbit, but you've got vessels that track up as anastomosis with the or end arteries of the facial artery, and the central is a branch of the dorsal nasal artery. So here you can see Kam is augmenting the deep fat compartments, and in the forehead there are three deep compartments. There's one central compartment and there's two lateral deep fat compartments. The forehead can be divided into three by the inferior frontal septum and the middle frontal septum. And here you can see Kam is in that middle frontal septum between the transition point of the vessel. The vessel will transition as it goes through the inferior, and just before it gets to that middle temporal septum, the vessel will have transitioned from below frontalis to above frontalis. So here it's really important to stay close to the bone beneath the galea so that you can end up in a safer avascular plane. But we ultrasounded this area earlier on, and what we could determine is these vessels are running about 2 millimeters above the bone. So this area does not have a safe, deep and superficial plane. The vessel is usually in an intermediate plane. There is no deep 2 centimeters below. The plane of the vessel is normally in around about 2 to 3 millimeters below the skin. You can see here now the light reflectivity, I hope you can pick it up, but from where I'm standing, the light reflectivity now has evened out that depression in the forehead. The point of this is that a feminine forehead has a nice 12-degree convexity that creates the dome of a female face. A masculine forehead will have a more oblique angle and more frontal bossing. So by placing the product here in that zone, you can see that the frontal bossing has been reduced, and that light reflectivity that was coming from the skull here through has also been reduced. And now it's a much more harmonious feminine forehead.
To ensure a smooth final result, I used my thumb to just roll along the product placement to ensure that there's an even distribution of it. And as you can see, because of the rheology of the product, it's created a smooth result, and that is often needed, and it's nothing to worry about. And the product rheology allows you to create a smooth final finish. And just to confirm, I use 0.3 mils. So it doesn't take a huge amount of volume. And Millie, were you comfortable throughout?
Absolutely.
Okay, perfect. And hopefully you could see that Millie was comfortable. There was no topical anesthetic or no infusion here. This is literally just relying on Millie's strength and courage, and then the 0.3% lidocaine that exists in the HA filler.
Moving on to the temple area, one of the other aesthetic subunits of the upper third. Kam has just done the forehead. We're now going to move on to the aesthetic subunit of the temple. And this is defined by a line that runs in the superficial temporal crest, along the orbit, and around and onto the superior portion of the zygomatic arch. It's delineated distally by the hairline. So this is now the aesthetic temple that we're choosing to augment. My technique here is going to be superficial in layer 2 with the cannula. I use the rheology of the product is going to be viscous to allow me to get a fine film of product, really superficial, to create and improve the lateral contour of Millie's temple.
So Jeremy, just remind us what product you're using and how you're going to place it in the temple.
So this is toxin RHA1. I use a 25 gauge 50 mil TSK Steriglide cannula to do so. I've chosen 50 mil because I can assess that I can get the full extent of that temple with the cannula. I'm going to go into layer 2. It's going to be a superficial injection. Now, many people inject with a needle as a one-up, one-over, or otherwise called the gunshot technique. But what we know about that technique, or what we know about the anatomy of the temple, is that there's a division into two compartments, a superior and an inferior compartment. If you just use the gunshot, you will only augment the superficial compartment. And what we know from the evidence is that the inferior compartment is the compartment that ages the most. There is no bony aging within the temple. It's all superficial and soft tissue aging. So my technique will be, I just lose the bevel. The reason I don't go deep here is because I don't want to end up going through the superficial temporal fascia. I want to stay superficial above the superficial temporal fascia. So here I'm now into the superficial plane, and these cannulas glide easily through the tissue. With a little bit of counter traction, I can get into and up through that superficial compartment. And now you can see how superficial I am. I am in layer 2. The danger here is going to be in this area, and you can see it, is the sentinel vein. So I'm going to deposit with my port up a small amount of product. I'm going to come right up to this superior temporal septum and inject a very small and slow amount of product.
How do you know which way your bevel is, Jeremy?
There's an arrow on my cannula which directs me to the direction in which the port is. So now I can see my port is up, and I'm going to just do some linear threads here and just gently gliding up to the lateral brow and back down.
Very nice. I think you're obviously showing us a very safe technique here, and the explanation you gave for using the cannula technique over the needle technique, often known as the one-up, one-over, or the gunshot technique, was that you can actually treat the lower temple as well as the upper temple. However, I think with more and more use of ultrasound in and before treatments, we're noticing that actually in this one-up, one-across position, more and more often on the periosteum, which is actually intramuscular because the temporalis muscle is fused onto the periosteal layer, we're finding the vessel in this position. And I know you're a fan of ultrasound, Jeremy. Have you noticed this as well? The
vessels are quite consistent, but what we know about the face is we need to picture the face as a three-dimensional puzzle. We all have similar componentry. We all have the same componentry. But what's different about us, what makes us look different, is the shape, the size, the degree of aging that we all have going on in our faces. This is why we all look different, but we all have the same componentry. Every one of us has exactly the same componentry in our face, but the way it's distributed, the shape, the size, the form of it is different. So I've just about completed that temple, I think.
Okay, just remind us how much you've used of the RHA one, please.
So I've used 0.04.
Okay, so just under half a mil.
And now I will massage away from my port, encouraging the product up and towards the deficiency. And I hope you can see that now we've improved and raised the lateral brow. We've improved the confluence between the forehead and the temple. And now there's a nice arc that goes from the temple, from the forehead into the temple and onto the zygoma. And so we've blended the zygoma in, and we've blended that temporal crest into that lateral contour, which is a feminine prerequisite. So we're reducing the skeletal look of the face. Let's look at Milly's midface. The definition of a midface is a line that runs from the lateral canthus to the superior edge of the tragus, and then an inferior line that runs from the inferior border of the tragus to the oral commissure. It's divided in the midline into a left and right side, but also you can divide the face into an anterior mobile section and a lateral fixed section. You can see the reason for this anterior mobile section is it houses the muscles of facial expression. Behind this lateral line houses the muscles of mastication. And so we want a mobile anterior section here for Milly to be able to animate. So if Milly was to smile, you can see the movement is contained within this anterior mid-face. We also know for female mid-face that we want a projection ratio of 2:1. So she needs an anterior projection of the mid-face and not a lateral projection of the mid-face. A lateral projection of the mid-face along the zygoma is a masculine trait. So when it comes to augmenting Milly's face, you can see she's slightly depressed in this area. Another way to assess the mid-face is to take a vertical line from the globe onto the cheek and check whether that vector is positive, neutral, or it's negative, which then would move us on to the tear trough. Because if the mid-face sits in a negative vector, then it's a contraindication to treat that tear trough. We want an anterior projection or at least a neutral mid-face before we would take on and augment Milly's tear trough. What we can see here is that she's going to need a slight augmentation here before we would try and treat Milly's tear trough and palpebral malar groove. Here we can see that Milly would probably need treatment to the tear trough and to this palpebral malar groove. She's got hyperpigmentation within that tear trough, which we would need to discuss and perhaps put Milly on some topical treatment to help her with that.
Moving on to Milly's nose. We can see that she has a petite nose. However, as we come down to the tip of the nose, it just widens. We can improve the appearance of this by improving the light reflex and creating a slightly slimmer bridge. The tip angulation and elevation is perfect for the female face, therefore we will not need to work on improving the tip elevation, and we will continue to improve the silhouette of the nose and improve that light reflex to make it look more contoured and slimmer.
The features of a feminine mid-face is to have this 2:1 ratio between the anterior and the lateral face. To achieve this, I would want to put my products in specific places. I still draw a map on my patients, so the learning outcome for this section can be the map that we draw on the patient's face is easily representative of where the product needs to be placed. And from an anatomical point of view, you will find if you're in these squares, you're in specific places. So let me draw that map for you. My first line goes from the pupil vertically down. This is a safety line. What we find is medially we're going to get the vessels. The angular artery will be coming up here, and at the point of the medial limbus, about a centimeter below and about 23 millimeters in from the lateral part of the orbit, you'll find the foramen of the infraorbital neurovascular bundle. So this line helps me avoid this section. Then I would drop another vertical line parallel from the lateral canthus down. I put a third line in, which is the orbit. The orbit always ends at the lateral canthus. Then I would put in the mid-face equator, and that goes from the alar crease to the top of the tragus. And below that, from the bottom of the alar, another parallel line. Now I've got on Millie's face some squares in which I know the anatomy that lies beneath, because in this square, in the deep plane, in layer 4, I'm going to get my medial souph. Here, I'm going to find in deep medial cheek. Here, deep piriform space. And here, I'm in my lateral souph. So, I now know where my deep fat compartments are. Superficially, we can see that in this section just here, we are going to find the medial, the middle, and the infraorbital fat compartment. And if you look on this side of Millie, you can see that the light is reflecting off that infraorbital fat compartment there. I don't know whether you can pick that up. So we need to avoid that, because what we know about the infraorbital fat compartment is it's prone to edema. So let's start. So my entry port here is going to be lateral. It's going to enable me to get into this medial souph. We're going to put a small amount into the lateral souph and a small amount into DMC, and then I'm going to put it superficially in a multi-layering methodology over the top of this.
We're using RHA4 here, which is a dynamic volumizing filler, which will enable us to create that deep volume and replenish that lost volume deep, but also replenish the superficial fat pads as well.
So for my technique, I don't go deep to the bone here. I very often see people going deep to the bone, but because we're going to use the SteriGlide TSK cannula, I want to get the haptic feedback, the benefit from using a cannula here. And so when I go through the layers, I can feel pop, 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 and that allows me to interpret the depth I'm at. So we've just lost the bevel through the skin. And now, with a prime cannula, I'm just going to get in the skin, with it. So here, now, by doing this, I can see that I'm above the SMAS. We can see that the tissue is all moving. We can see that I'm superficial. So with my non-injecting hand, I'm going to pinch all of these tissues up and out, and then I'm going to pop. There'll be a pop here, and then there'll be another pop. And now I can only be in the deep compartment. If I lift this, there's no chance you're going to see it. I sometimes see people trying to feel it. They won't feel it either. So now I know I'm out about 25 mil and I'm in about 25 mil. So I can only be in that medial souph. I'm going to inject super slow.
What sort of volume are you looking at injecting here, Jeremy, in the medial souph?
So I'm actually watching the patient's face. Mm-hmm. I'm looking for the outcome, the changing in the surface topography of the face. But what we know from work by Kotafana is that the medial souph will give the greatest surface volume coefficient of all of the fat compartments of the face. And so we almost get a one-to-one relationship with the product we're putting in relationship to the difference it makes to the surface of contour of the face. And the reason for that is the souph is quite close to the surface, whereas the DMC it's a much deeper fat compartment because we know that the maxilla goes backwards. So now I've put in a small amount, I don't really know, but I can see I've got some elevation. And now I'm going to lift, and I'm going to go again deep down onto bone, and I'm holding this tissue away. So I'm going to be sub-SMAS, and I'm going to again release it, and I'm just going to put a small amount of product in here just to give a small amount of support in this lateral SOOF. From there, I'm going to lift the tissue, and I'm going to aim into this DMC. And what we know about the DMC is you've got to change your angle because the skull goes backwards here. You've got this maxilla that's retroclined. And if you don't angle up, you're going to end up going superficial. So here I'm just going to again put a small amount of product in and watch what happens. Now I'm going to release the SMAS. And if you ask Millie, she could feel that there was a little click then where I've released the SMAS away, and now I know I can only be in the superficial plane. Now I'm just going to come superficial here, and now you can see I'm superficial, and I can only be in that medial superficial fat compartment. I'm not at all going to go into the next click. The next click will take me into the nasolabial fold, and I'm just going to contour a small amount of product into this area.
And I can see as you're going forward, Jeremy, you're making sure that the cannula almost curves to avoid that infraorbital fat pad, which, as we know with the aging process, can often start looking a little bit puffy or edematous. It does have delicate lymphatic channels going through it, and either using a needle or a cannula in that area will damage those channels, or even placing products there can often impair lymphatic drainage, causing a puffy appearance in the under eye area, which makes the patient look more tired rather than rested.
So we very often see people say after injection, gentle massage. I really think that word is incorrect. It should be a gentle mold, because what we're trying to do is contour the patient's face. Massage to me means you do this, you just push down all of the contour that you try to make. What we try to do with filler is sculpt. What we want is to create contour and not just put product in. So we want to use a minimal amount of product, create the maximum benefits for the patient, because we know that too much product in this area is going to create that unnatural overfill syndrome.
So just remind us, Jeremy, how much product you use deep and how much product you ended up using in the superficial fat pads, the medial and the middle superficial cheek fat pads.
So in total, I've used 0.5. I've used 0.1 in the SOOF, medial SOOF, 0.1 in the lateral SOOF, 0.2 in the DMC, and then 0.1 over the top of it, superficial, taken into the median and the top aspect of the middle. Because what we know about the middle fat compartment and the middle fat compartment is as they age, they go under different, there's a different process. And the process is that this is a volumetric change, but here in the middle fat compartment, there's this inferior deflation of the adipocytes. So you need to restore the superficial, superior component of that middle fat compartment, but you need to revolumize the whole of the median fat compartment. So that concludes the way I would normally do my midface. And normally I would use 0.6 on either side. We don't need to use much product in this area. Put the product in the right place, put the product in the right tissue plane, choose the right product, and you're going to get the right outcome.
As we saw with Jeremy going from the superficial fat into the deep fat and traversing the SMAS layer, the tool that you use is very, very important. Using the TSK Steroglide cannulas that are dome-shaped and rigid enables you to smoothly transition through the SMAS layer rather than having a buildup of tension, which can sometimes result in the buckling of a cannula or a sudden release of force as you get through the SMAS. Obviously, this is more traumatic for the patient and can cause more pain. However, it's also more dangerous because if you're pushing a metal force through a layer, it can actually penetrate a vessel wall. Whereas with controlled force and a rigid cannula with a domed tip, such as with the Steroglides, then you have a lower risk of doing this. When looking for the perfect tools for your treatments, TSK is a perfect partner. what inspired me to work with the TSK portfolio was actually when I opened the fillers that I use, a toxin portfolio, there are TSK needles that come with the filler. So if I'm using the best filler and they come with the best needles, I wanted to dive deeper into their array of products. And ever since using TSK Steroglide cannulas, I can honestly say hand on heart, I have not used any other cannula because it satisfies all the needs that I have for treatments and I've not needed to look elsewhere.
For me, I use a lot of 4mm needles. I find from a safety point of view, it keeps me honest with the depth. I get incredible results because what I'm doing is placing product really superficial. So by placing the product superficial with the 4mm needle, I'm getting much more benefit from the product that I'm placing. So I can place less product in my patients, and so my product goes further. I don't end up overfilling them, and I get exceptional results.
If you want to know more about the TSK portfolio and see what they can offer you to help elevate your practice, please visit www.tsklab.com. We are now going to assess and treat Milly's tear trough area. The primary learning outcome of this section is actually patient selection. If you select the incorrect patient for this treatment, regardless of your technique and the product that you use, you will have poor outcomes. Therefore, first and foremost, looking at your patient, they need to have a true tear trough. What is a true tear trough? It's actually a depression or an indentation from the medial canthus running to the midpupillary line. That is where the tear trough ligament is, and if they have an indentation or a depression there, that is a true tear trough. Laterally, sometimes referred to the lateral tear trough, is actually the palpebro-malar groove. So that's another depression that can appear between the cheek as it deflates and descends with the aging process and the true orbital rim. There are a couple of tests that we can do which also helps determine if the patient is a good candidate for treatment of this delicate area. One of them is called the snap test, whereby we pinch the skin, the delicate skin of the eyelid, and see roughly how long it takes to return to normal. A prolonged return to normal, anything above about 4 or 5 seconds, shows that there's significant loss of elasticity in this skin, and any product that is placed here may actually end up creating a bulge or looking like it's overfilled. Secondly, what I like to do is something called the pressure test, and thankfully Milly doesn't actually have any bulge here for me to press on. Often there is a bulge, and it can be commonly due to 2 factors. One is periorbital edema, which is due to poor lymphatic drainage in this area, and that can happen because of genetics, or it can happen because of overzealous treatment to this area with either a cannula or a needle that can either damage the lymphatics, or if filler is placed in the superficial plane and that actually impairs lymphatic drainage. The other common reason there can be fullness in under the eye is if there's actually herniation of the infraorbital fat pad. And the way to test this is, as I referred to earlier, the pressure test. If on pressing you see that there's fluid and it just squidges to the sides, that's to do with periorbital edema and it's to do with drainage. If, however, when you press the fullness under the eye and you see the whole globe move up, that's more likely to be infraorbital fat pad herniation, and the only real treatment for that is surgical. So it's very important that your patient is aware of those 2 factors, and thankfully Milly doesn't have that, so we can skip that. And then finally, it's very important that you examine the skin, and I call it the stretch test. And what that's actually highlighting is if we eliminate the shadow that's created by the indentation of the tear trough deformity, then you're looking at the pigmentation of the skin. And often when you stretch the skin, it will highlight any superficial pigmentation. And Milly does have some because of her Greek descent. She does have some freckling and irregular pigmentation in the under eye area, which is contributing to the appearance of a tear trough because it's merging with the shadow created by the depression or deformity. The other thing that you may notice in this area is a deep red maroon color when you do the stretch test, and that's because the skin has thinned so much, or often in Fitzpatrick's types 1 and type 2, there's such a lack of eumelanin there that you see the muscle, you see orbicularis oculi through the skin because the skin is translucent. Therefore, after doing these tests, we can determine that Millie is actually a good candidate for tear trough treatment, and that we can directly treat the tear trough and help elevate the depression in this area.
One thing I would add to that is the positive, neutral, and negative vectors when you look at Millie in profile. If the globe sits behind the anterior part of that midface, then that is a positive vector. But if the globe sits in front of the midface, then that's a negative vector. And if it's parallel, it's neutral. You need to assess that prior to doing the tear trough, because if you do the tear trough and it's a negative vector, as Kam was saying, you'll end up with a suboptimal result. You'll overfill an area that needed the midface doing first, because sometimes you're going to get an indirect improvement into the tear trough by improving that medial SOOF of the midface. So it's important to do a profile assessment and just check those positive, neutral, and negative vectors before you begin. That's, again, a really strong learning point. Assess the profile as well as front on.
And we would normally advocate treating the tear trough indirectly with an anterior midface rejuvenation prior to considering direct tear trough treatment. And of note, we've had the patient sit up for the whole time that we do these assessments, and this is essential to get a true representation of a tear trough deformity. So when it comes to just before treating, for me, the only thing I like to draw on is the orbital rim, because that is a hard stop when it comes to your product placement. If you go above or beyond the orbital rim, you can often go through the septum and be intra-orbital, and that is not a place that you want to deposit your product. Therefore, I'll just mark this on. And often you do have to stretch the skin and make sure that you do palpate the orbital rim. And just as a reminder, I will be using a 25 gauge 50 ml cannula, and the product I'll be using will be Redensity 2 by Toxin, which is specially formulated for this delicate area with regard to its rheology, but also its biochemistry, which helps support the fibroblasts here and helps thicken the skin. Anything else to add to that, Jeremy?
Very often people say that they're augmenting the tear trough, but the tear trough is a true ligament. And where the space is below that ligament, and it's in the nasojugal groove. So Kam will be sliding along the bones towards the median canthus, but he will be in that nasojugal groove. He will not be in the tear trough, because that is technically, anatomically, a ligament.
Okay, so just showing, I use a 23 gauge trocar, and now I am on the actual periosteum and the bone, and I often lift up the tissue and then just glide the cannula along that surface. If you just open your eyes for us, Millie, and look up to the ceiling, that's just an extra layer of safety here, because by looking up, you're moving the globe away from any potential cannula or needle tip, depending on what method you use. I'm using my non-injecting hand to just ensure that I can palpate the tip of the cannula, because if I try to lift it up, you'll see that there's nothing to see, because we are on the periosteum, and as I edge closer and closer to the medial canthus, we've got the edge of the orbit gradually rising, and you've got the tear trough ligament and orbicularis oculi fusing onto the bone. And we're essentially, the more medial we are, it's really an intramuscular injection, even though we like to think that we're purely on the bone, we are actually in the muscle. And the key learning point here is small, tiny microboluses, and that less is more, because even though the product that we're using has got optimized hygroscopy for this very delicate region of the face, it will still draw in some water. Therefore, the finished result is usually in about a couple of weeks' time. So always, always, always undercorrect.
How do you feel about that entry port, Kam? Is it up? Is it down? Is it sideways? What's your preference and why?
With regards to my entry port?
Yeah.
My bevel.
Bevel, sorry.
Okay, so good question. if I know I'm on the correct plane because I'm gliding along the periosteum, I actually have my entry port or the bevel facing up, because as soon as I leave a bolus, I will feel the SMAS layer, which in this case is orbicularis oculi, lift up. You can also do the same and point the bevel directly down onto the periosteum. Do you have a preference?
So I think technically the preference would be if you're going to use a lot of extrusion force and the port is up, then you've got the danger of extruding the product through the fibers of orbicularis oculi.
Yep.
Whereas if the port is down, you're putting it onto the periosteum. So I would favor that, because what you don't want is to extrude through that muscle, and that will create 100%, that will create edema, because then you're in layer 2.
And we know that the muscle is actually fenestrated, which means it's got small little windows in it. So actually, if you are pushing with a high amount of force, you will end up pushing some of that product through the little windows in the muscle. However, with the cannulas that we're using and combined with the product that we're using, we don't actually need to use a high extrusion force, and I can control my microboli that I put in there. So I have used 0.3 mils in the medial tear trough deformity region, or in the nasojugal groove, as Jeremy likes to put it. And now what we'll do is just reassess Millie and have a look at the lateral aspect of the tear trough, or the palpebromalar groove.
So the anatomy is slightly different here. In the tear trough, you've got the 3 layers: skin, muscle, bone. But once you pass that mid-papillary line, you've got the conventional 5 layers. You've got skin, superficial fat, and here it'll be the infraorbital fat. Below that, you've got the SMAS, and here it's going to be orbicularis oculi. Below that, you've got the SUF, and below that, you've got the bone. That's a simplified version. There may be a couple of more layers, but for all intents and purposes, it's a 5-layered system lateral to that midline, and a 3-layer system medial to that midline.
And I've changed my tool that I'm going to use to deposit the product. I've now gone to the invisible needle, and this is because I will leave microboli on the periosteal surface, and I want to create minimum trauma and a minimum discomfort to the patient. So what I like to do is often just add a bit of counter traction, and I normally use a C grip, whereby I'm protecting the eye and I'm using my thumb to apply counter traction, and then we go down onto the orbital surface and I'm there already. So just extruding a small amount of product. You can see that the needle is delicate and causing minimum trauma, because as soon as I touch the bone, the needle is just flexing a little bit. That's 2 microboli, and then 1 more, and I think should do it. And the great thing is here, this area it's got lots of superficial vasculature, and using a needle that's this precise actually enables me to skirt around it. And discomfort-wise, Millie, how would you say that was?
Really good, no discomfort at all.
Okay, perfect. And that's using a needle quite near the eye. So that is a combination approach to tackle the tear trough. We're now going to augment Millie's nose, and the aim of treatment here is to essentially just create a slimmer profile, slimmer front profile, and have a nice thin light reflex on the anterior surface of the nose. What we will do is also help just give a slight slimming effect at the base of the alar by augmenting the piriform fossa as well with some product. So the technique we will be using will be predominantly a cannula technique, and here we're going to be using a 22 gauge 50mm cannula. So we're using a larger gauge cannula effectively for safety, and the aim will be to glide along the perichondrium and the periosteum, knowing that the vessels are usually in layer 2, but using a larger bore cannula will add that extra element of safety. The vessel position has been confirmed by us with the Clarius handheld ultrasound prior to injecting. And also the second reason for using the 22 gauge Steroglide cannula is because we're using Tioxane Ultra Deep. So this product is 10% cross-linked, and it's got 25 milligrams per mil of hyaluronic acid. Therefore, it makes it quite a rigid product. And as a result, using a larger bore cannula helps us just reduce the extrusion force that we're using to deposit the product, and therefore adds another element of safety.
The nose is a static area, so we can use a product in the toxin range and the PureSense range that is a static product.
Yep, so here I'm just marking out the alar triangles or the piriform fossa. So the aim here would be to use a needle actually to deposit product on the periosteum or the bone. In this position, usually the danger area is superficial or in layer 2, but it can also sometimes be on the periosteum. Again, we've checked this area with the ultrasound to ensure that we are in the plane that is not where the danger is. Onto the actual nose itself and the marking up. So the key thing here is to ensure that we have a consistent midline that sits with the other features of the face that you would normally associate with being midline, such as the glabella and then also the Cupid's bow. And then sometimes the chin, but the chin can be skewed to one side or the other, and we have the option of augmenting that to bring it to the midline. So a good thing is to look or lean over the patient to make sure that you can draw a good midline position, or you could do that from the head of the couch, but Jeremy is too comfortable there now to move, so I'm just going to have to stick to this side.
I've checked it, it's perfect.
Okay, good. The main areas we're going to deposit product to augment this nose is actually we have a dorsal hump here that needs hiding. So we need to just put some product slightly superior to that and lift that out. We have a very, very small supra-tip saddle that is creating a small concavity in the light reflex that will then augment. And then finally, we've got a slightly bulbous nasal tip. And what we'll do is just augment the nasal tip by creating a sharper light reflex on the anterior aspect. When we did the global assessment earlier, we actually looked at the tip projection and we saw that the tip had good projection and elevation. Therefore, we don't actually need to augment the columellar area or at the base of the nasal spine. And this is often a danger area too, and thankfully we won't need to augment it.
There's also a difference between the male and the female nose in general terms. The angle here between the forehead and the nose, the nasofrontal angle, is more obtuse than in the male face. And again here the nasolabial angle is more acute in a male than it is in a female. So we need to remember that there is some gender dimorphism here with noses. A male nose might have more of a dorsal hump than a female nose. A female nose is going to have that elevated tip.
The other thing, the nose is a highly vascular structure. As long as you know where your danger areas are, when you do make your needle entry point, you may get a small trickle of blood, and the key thing here is not to panic and know that there is significant vascular regional overlap here. So the other thing is to just ensure that the patient is aware that they may get a little bit of bleeding or bruising post procedure or during the procedure. So I'm just using my 21 gauge entry point and making my entry point just there. That's a little sharp scratch. I leave it in for a couple of seconds just in case we have potentially gone directly into a vessel and we get immediate flashback. I've primed my cannula, and Jeremy, if you could remove the trocar, that would be great. We've got that tiny little oozing of blood and we're in. So I am now just lifting up the mobile layers of the nose and just gliding along that periosteum and the perichondrium, and we have quite comfortably got to the glabella area, and hopefully on camera you will be able to see my tip of the cannula. Now, because of the dorsal hump, the tip of the cannula is elevated. Therefore, I need to actually elevate the barrel of my cannula to drop the tip of it onto the periosteum, or as close as. And I use my thumb and forefinger here to restrict the lateral spread of the product. And I'm just leaving small microboli in a retrograde fashion to just elevate the area superior to the dorsal hump, and I've used, fractional amount here, less than 0.05, and now I'm just going to reverse back and just see, and already we can see we've really softened that nasofrontal angle. The important thing here is we must maintain a nasofrontal angle. We can't have the nasofrontal angle obliterated and have the nose running straight into the forehead. That is not a natural look, and it certainly defeminizes the nose, and it's more masculinizing than anything. So I'm just going to go back in to that same compartment and also just deposit a little bit more product there.
And you can see, I can see from where I'm standing, that the shape of the cannula is creating some light reflectivity right down the middle, which is giving that illusion that the nose is getting narrowed as Kam is working on this.
Yep, and then I'm quite happy with that. We will massage and mold it a little bit afterwards. I'm going to just bypass the dorsal hump completely. We don't want to put any product on the dorsal hump here because it'll exaggerate it and undo some of the good work that you've done superior to it. Then in the actual super tip saddle, I'm leaving another couple of microboli to connect the dorsal hump to the tip to effectively create a confluent light reflex. And as we are coming out, what I will do is just create a slightly sharper light reflex in the tip, and basically you'll see a little bit of blanching on the depending on the tip position of the cannula, and that's where you will leave your deposit to create a smoother light reflex. And what I like to do is I like to pinch the tip and then just leave a small deposit where I want the light reflex to finish. Okay,
and that's the advantage of having a cannula here that is relatively firm to be able to position the product exactly where you want it to go.
So I'm just having a little look on this profile view, and I can see that we are probably a fraction off where we want to be in the super tip saddle, and I will just put a little bit of product there. If I needed to go down to the nasal spine, what I would actually do is, leaving my cannula inside the patient's nose, I will actually change direction and go down through the columella to the base of the nose and augment it that way. So actually you can still use the cannula to do all of this.
Alternatively, you could use a needle and go directly down onto the nasal spine.
What are the vessels there that we need to be wary of, Jeremy?
Well, you've got the columella connection from coming up from the lip, from the superior labial artery. You've got columellar arteries that come up, and they all are confluent at the tip of the nose. So there's a lot of vasculature at the end of this nose. So sometimes you can get a complication on the nose from doing the lip. So it's something that you need to be very careful of, and obviously vascular mapping is very important in the nose. The nose is the highest rate of blindness of any of the aesthetic subunits. So we need to be super careful, and it's not something you take on lightly, and it's not a Tinkerbell nose lift. And this is the most highest risk area of the face.
Okay, so I am pretty happy with that, and the nose cannot just be examined in the AP view. You must look at the lateral profile view to see actually if you've created a smooth profile and contour. Jeremy, you're in prime position there with that bird's eye view to just give me an update on how that light reflex is looking centrally.
So you can see the light reflectivity. I hope you can see it. I can see it, that it's now consolidated down the middle of that nose, and it's created the illusion that the nose is narrower. It's counterintuitive. You put in a product into the nose which is going to make it essentially bigger, but by systematically placing it strategically, you're creating a narrower bridge, and so the nose now looks narrower than it did before we started.
Okay, and now just to treat the piriform fossa, I'm switching over to a 27 gauge needle. It's a standard TSK needle, and it's 13 millimeters length. So what I'm going to do here is, I usually go in at a slight angle around 45 degrees because I want my bevel to sit as flat on the periosteum as possible. Again, it's just a small factor that I take into account, which will help minimize risk, because I want the whole bevel as flush as I can on the periosteum, just in case the tip of the bevel is on the periosteum, but the initial opening of the bevel, which is a couple of millimeters away from the tip, could potentially be in a vessel. But remember, we've already scanned Millie here, so that's just an extra precaution.
For me, I do that slightly differently. I've got two different ways of doing that, actually. I would go in at 90 degrees at this point.
Perfect.
Because in my head, what I think is, if I'm at 90, my thumb is directly above the needle, so I know exactly where I'm depositing at that point. And also, I sometimes come in from the cutaneous lip, and I will, with a cannula, pop myself into, at about a 30-degree angle, I can get into the premaxillary space, and then the deep piriform space comes deeper than that. So I can get into 3 different planes from the same injection point.
Okay, so again, Jeremy, you're in a good position to see.
Yeah, so you can see that this now is elevated here, beautifully.
So I've used 0.2 mil total in the nose, and I've used 0.2 mil in the piriform fossa on this side, and obviously we'll match the other side. And this has had a twofold effect. One, it's nearly obliterated the nasolabial fold indirectly, and secondly, it'll just help reduce that intra-alar width, and that concludes our nasal augmentation. So I used a 27 gauge needle here as opposed to something like a 30 gauge needle, because the product is highly cross-linked, and also that contributes to its cohesivity. So I wanted to reduce the extrusion force to make it that much safer. The other great thing about the 27 gauge TSK needles is that they are thinner walled, and therefore that helps with the bore size and the extrusion force, again making it easier to inject and overall a safer procedure for the patient.
Let's look at Milly's lower third. The definition of the lower third is a line that runs from the inferior tragus to the oral commissure down to the mandibular border. It has a divide at the midline into a left and a right side. The lower third contains the jawline, the chin, and the perioral area as aesthetic subunits. So now let's look individually at those aesthetic subunits. And if we take the perioral area, and if Milly blows us a kiss, we can see that there's early signs of loss of volume in the cutaneous lip. Milly has beautifully proportioned lips, but they have a slight amount of dehydration, and maybe a small amount of hydration will enhance those lips. We can assess the chin by using either the Burston line or the E. Ricketts plane, and assess against that line the distance the lips are behind that line and the relationship of the tip of the nose to the pogonian. And we can see that Milly is mildly class 2 division 1, which means skeletally her chin is retrognathic. So when it comes to enhancing this area, we would enhance the upper cutaneous lip. We refresh Milly's lips, and we need to project the chin forward to get into that E. Ricketts plane. We also can see in anterior view that the chin is a little bit wide. And so by projecting at the pogonian, we can create the illusion of narrowing the chin into that neoclassical middle fifth. When we look at the jawline, you can see there's a break in the jawline at the jowl. There's pre-jowl sulcus, and if you look at light and shadow, you can see there's some shadowing here. And if we can bring this out into the light, it will make that area look a little bit younger. We will not put any product into the jowl. The jowl is created between 2 ligaments, the mandibular ligament and the paratomesenteric ligament. And when we spoke about this anterior mobile midface, we know that this descends with time into this area here called the jowl. Milly's jawline is exceptionally good, but it needs some small enhancements to create the true beauty that lies within. That concludes my assessment of Milly's lower face. So now we're going to move on to Milly's lower face. And here we're going to divide it into 3 different subunits. We're going to divide it into the perioral area, the chin, and the jawline. And I'm going to start here with Milly's chin. During our assessment, we could see that Milly's chin was a little bit wider than that middle fifth of the neoclassical canons. We also can see from profile that the chin is a little bit behind that Burston line or the E. Ricketts plane. And by bringing the chin a little bit further forward, we can enhance Milly's profile. We also, when you can look down the camera at Milly's chin, you can see it's a little bit asymmetrical. She's more forward in this right-hand side than she is in the left-hand side. So it is my intention just to place a bolus in the midline. We know the dangers of running 6 millimeters either side of that midline, the ascending submental artery, and it's running around about 4 millimeters deep in layer 3, 75% of the time, and layer 2, 25% of the time. So a central injection for the female face will harmonize and bring that lower face down into a more feminine point at the tip. So for me, I would always mark this in the midline. We would follow that midline through and just mark it. Now, we assessed earlier on that the lower third didn't need any elongation. So I'm not going to place my product at the menton. I want some anterior projection, which is the pagonian, which I've just marked there. So I'm going to go down onto bone, and I'm going to place a bolus, a small bolus of about 0.2 or 0.3. And then Kam is going to come over the top of it and multi-layer in layer 2 to create more contour in the next section. So for me now, I'm just going to my product. This product needs to be confined because what we don't want to do is to allow it to spread. So I'm going to use my non-injecting hand to hold the product into the area I want it. Sharp scratch. I'm going to go down onto bone, and then I'm going to contain the product within this area. I'm not forcing the bone. I'm pecking up and down because I'm not trying to get it under the periosteum.
And here we're using ultra deep by Toxin because it's 10% cross-linked and it's 25 milligrams per mil, so it's highly cohesive and quite a rigid product, which gives you more projection per unit volume used. And Jeremy's depositing it using a 27 gauge TSK needle, which again allows the extrusion force to be lower because it's thin walled, which gives you a wider bore and helps with the element of safety and comfort for the patient.
We also know that this product being so cohesive will end up pushing me away. So I'm tapping back down to making sure that I am in the right tissue plane. So, done. I think that's brought that beautifully into the middle, into that middle neoclassical cannon, that middle fifth. So important in the female face to get that middle fifth consistent. So, in profile now, you can see an improvement in the forehead, and the dome with the forehead now is much more feminine. You can see the Kam's work on the nose has created a really elegant nasal tip and reduced the nasofrontal angle. And then when we follow it down onto the chin, you can see that there's this projection now that improves this Erick's plane. And so we've got a really feminine, beautiful profile that we've created, an unbelievably nice chin line here, and that this just small amount of product has created that projection. Not only has it brought the chin into the midline and into that neoclassical cannon, but it's projected it so that the profile view is much more feminine. I hope you can see that at home, and that's a really good learning tip to look from the side of the patient's face.
Now we're going to augment one of the commonest treated areas globally, the lips. If we have a look at Millie's lips, she actually has very nice lip shape. What we've noticed is actually she's got a bit of deflation and a bit of dehydration. So what we're going to do is just very gently restore some volume and hydration into those lips. The product that we'll be using is RHA2 because it's malleable and it gives a subtle amount of volume, nothing too much. That is the last thing Millie wants, is over-projected, over-treated lips. And to minimize trauma, I'm going to be using a 38mm 25 gauge TSK cannula. And I'm using that because, again, I want to minimize trauma. I don't need the length of a 50mm cannula. I'm so used to using a 50mm cannula, it almost rolls off the tongue. But because of the length of the lips, a shorter cannula is better here. And again, using the Steroglide is a little bit more comfortable because it glides smoothly and it's got that domed tip. The aim would be to make a single entry port just outside the oral commissure, with regards to danger zones here, if we use the rule of thumb, we know that the vessel, the facial artery or angular artery as it transitions to, is around about 1 to 1.5 centimeters lateral to the oral commissure. And what my aim will be is to make my entry point around about 5 millimeters from the oral commissure. Sometimes you can have a superficial vein that runs along that area. So it's important to make sure that you avoid that and make your entry point and then pop the cannula in. With the cannula, my aim will be to stay in layer 2, so just below the skin in the subcutaneous fat of the lip, which will do two things. It will help with the appearance of eversion of the lips, because with the aging process you do get some element of inversion, and it will also gently volumize the lips in a natural sense as well.
We've made Millie a little bit numb, but again with this technique I think cannula is pretty much as painless as this technique can be. Think for needle, I'm a needle guy in the lips usually. I use a 4 millimeter short needle. Then I think that potentially has more pain involved. But the only place that I ever anesthetize my patients is for the lips.
Just gently open your mouth for me, please, Millie. Thank you. So what I do is my non-injecting hand will add a bit of counter traction to the lip, and then the cannula usually will glide quite comfortably. If you're getting a little bit of tissue bunching, and usually the patient, you'll see if they're in any level of discomfort, what you're doing there is you're actually starting to snag orbicularis oris muscle, which is layer 3. So again, counter traction, gentle pressure, and there I am underneath the GK point, and I'm in the correct plane. What I like to do is leave a small bolus right underneath the GK point, which will just help elevate it. I just need to go slightly further. Sometimes it's easier to push the tissue over the cannula rather than force the cannula forward through the tissue. My bevel is facing outwards here, and I'm leaving a tiny little bolus within the GK point there, and you can see that that's just created that small amount of definition. And what I'm going to do now is just a few retrograde linear threads of this quite soft product, which will just gently hydrate, rejuvenate, and revolumize. And my general advice is, if you're unsure with regards to how much volume you want to use, is roughly 0.15 per quadrant of the lips, because you can always go around again and add more. And the benefit of that is that the lip will be numb from the inside as well, because of the 0.3% lidocaine that's in the product. So I've just used 0.1 exactly there. And I know Millie is conscious of making sure that her lips don't look over-treated and they look natural. So I'm going to stop there. And what I'll do is I'll flip into the bottom lip. And usually, if you just add a bit of counter traction, you'll see that it just glides straight through, and we're in the center of the bottom lip. Remember, with regards to the embryology and the development of the lip, what you may have noticed is that I didn't actually go beyond the GK point, because the upper lip is composed of 3 tubercles, and the predominant volume is in the lateral 2 tubercles within that middle fifth of the face that we spoke about. The bottom lip is actually only 2 tubercles that join during embryological development, and they're almost teardrop shaped. So as a result, I'll be leaving product to respect that teardrop shape. The other key thing to note is the top lip is a straight line, whereas the bottom lip is a curve. So the good thing about the TSK cannulas is, even though they are rigid, they will flex enough for you to respect the curvature of the bottom lip and actually curve around. So I do this by ensuring that I put my thumb and forefinger there and then curve around like this. And you'll see that I'm not leaving a straight line there, I'm actually leaving a curve, and the flexibility of the cannula actually allows me to do that.
It's a very interesting point that Kam has brought up about embryology, because so often you see people nowadays with just straight line lips. Mm-hmm. What we need to be conscious of is that you've got an anatomical basis into which you want to create the natural enhancement and not an exaggeration of their lips. So following that embryological development, you can see that the lower one has 2 tubercles, the upper lip has 3 tubercles, and we know this from embryology. And that is the easiest way and the easiest learning outcome to do lips from this, is to remember your embryology and augment the lips accordingly.
Perfect. And one thing that Jeremy and I generally don't stick to is ratios. But if we were to look at the upper to lower lip ratio, in the Caucasian European white lip, effectively you'd have a 1 to 1.6 ratio, often known as the phi ratio or the golden ratio. And the way we've revolumized that, I'd say pretty much we've respected those characteristics, almost subconsciously here, where we've got a sort of a 60-40 split between the upper and lower lip. And the total amount I've used across both quadrants is exactly 0.3. So we can see that bottom lip is now gently augmented. The light reflex is more anterior, as it should be, and it looks plumper and hydrated. Yep. So the lips are now equally matched, and we will repeat the same on the other side.
So the dangers in the lips have been well established. Cotofana in 2017 and again in 2020 has identified where these vessels are. And what we know is that if you stay in the subcutaneous plane, it's around 3% now. It was 2% when he did the dissection, but now they've used ultrasound. He's found that the vessel occupies this subcutaneous plane about 3% in the upper lip, but in the lower lip, it's around about 7%, and the vessel meanders through the tissue planes more in the lower lip, changing about 25% twice in that lower lip. So if you want to reduce and mitigate risk, stay superficial. Don't be plunging your needle or your cannula deep into these lips. Stay superficial. You get more bang for your buck if you're closer to the ceiling. You get a better, quicker result with less product by staying close in that safer tissue plane.
That's it. So just to recap, as Jeremy said, the danger area is actually just beyond the wet-dry border there on the mucosal aspect. So with my cannula, not only have I used a blunt-tipped object, I've stayed in the subcutaneous plane to add another layer of safety. So lips are often the first thing that we're taught or we learn, but both Jeremy and I agree that one of the hardest areas to treat well and also treat safely. Hi, Dr. Kam Lally here, cosmetic physician. I've been practicing for about 10 years, and my favorite TSK product is the 25 gauge 50ml TSK Steroglide cannula. It is a jack of all trades product. I can use it anywhere in the face, and it's a perfect compromise between comfort and safety.
Wow, because that is also my favorite cannula. I absolutely agree with Dr. Lally that we have a perfect instrument that can do every single aesthetic indication of the face. The TSK 50ml 25 gauge cannula is my go-to. We're going to continue now with further development of Millie's lower third. You can see that there's a slight depression, and we know as we age there is a depression and a resorption in the bone here. We also know the mandibular ligament comes down here, and the jowl is created behind this mandibular ligament. The pre-jowl sulcus is just in front of this ligament, and a small amount of product directly on the mandibular border will create a significant improvement in the contour. So from where Kam is standing, I'm sure he can see that there's a depression just there on either side.
Yeah, that's it.
So for me, I'm going to go in. I'm going to use ultra deep again because I'm going into the deep static compartments. I'm going to put my finger along the border in the same direction, and then I'm going to come 90 degrees across it, sharp scratch. And I'm going to go down straight onto bone. If you don't hit bone quickly, I'm on bone, then you've missed your target. You need to get that mandibular border. It's a small injection onto the border. I'm not forcing it under the periosteum because that will be more painful. I'm just pecking down to make sure I'm staying in the right tissue plane. And there, I would come back out and just see how much correction. And I think probably, Kam, you can see already with 0.05, I've created an improvement. Kam will be multi-layering here, or as Kam likes to say, the sandwich technique, because he likes food. But we are going to just do the deep injection on the other side, and then we're going to use a multi-layering technique, the beauty of the multi-layering technique is it's going to augment the deep and the superficial fat compartments. And we know that we lose both deep and superficial. If you're only augmenting deep or you're only augmenting superficial, you're not fulfilling the full treatment protocol that the patient will inevitably need once they've passed the age of 25. So remember, there's a multi-layering technique for a reason, and the reason is fat ages in both the superficial and the deep compartments.
On to augmentation of Milly's jawline. So here we're going to be using RHA4, which is a dynamic product, and we're going to be using a 25 gauge 50 millimeter cannula to deposit the product in the subcutaneous plane. We'll demarcate the anterior and posterior border of the jowl, which are sort of arbitrary demarcations. And what we'll do is we'll go into the heart of that and then be able to access the jawline, or creating the mandibular line. And the technique here is actually to go in at the most inferior point of the jowl and lower the mandibular line. Because actually, if you go in where the true mandibular line sits, what you'll end up doing is actually widening the mandible and masculinizing the lower face, rather than creating a smooth and sharp jawline that masks the jowl. The other thing that you can do from this area, as I mentioned before, is augment the marionette line and the oral commissure, but also this general area of volume loss that happens with the aging process. This universal entry point will allow you to augment that. And then finally, as hinted at earlier, with regards to multi-layering the chin, we will augment the subcutaneous plane of the chin here to just ensure that we create a nice smooth contour and that the chin actually belongs and blends into the rest of the face.
So as a learning point for you at home, I think there's a sequence of events when you're injecting the jaw deep. You need to start with the chin to give it some projection, and then move on to the prejowl sulcus. And sometimes, but not often in a female, you might need to do the gonial handles. But as Kam was saying, you've got to be careful with the jawline of a female not to masculinize it. And there's gender dimorphism here. So you do not want to create sharp angles in or width in the female jawline. There is actually some danger here as well. We've got the facial artery coming onto the face just in front of the masseter. So here, Kam needs to be superficial because we know the danger here is deep. And you can see the outline of the cannula, how superficial he is. And he's now, from where I'm standing, bang on where that depression of the prejowl sulcus is.
So what I've done there, using my entry trocar, going into the heart of the jowl area, just anterior to where the facial artery would cross the border, the anterior border of the masseter, I'm doing a bit of subcision. This is what this is. I'm not injecting any product in, and you may be able to see the cannula just catching on some retinacular fibers here. So by doing this, you actually reduce some of the lines that appear in this area, and you're also mechanotransducing the fibroblasts into producing a little bit more collagen. So there is method to our madness. However, just bear in mind this can be a little bit uncomfortable, despite using the Steroglide cannulas, which are relatively frictionless and they have a domed tip, which makes it all that much more comfortable to just break through these fibers. Once you're gliding through quite smoothly, then it's worth putting some product down. And remember, if your patient is feeling the discomfort more than you would anticipate, then actually leaving a small amount of product is a kind thing to do, because the 0.3% lidocaine will help numb that area. So here I'm just putting some product in that area of depression that I've marked out. Thankfully, Milly doesn't really have a labiomental crease that I need to be concerned with. And what I'm going to do now is multi-layer more towards the chin and just help blend that chin into the rest of the face. And we can see that the cannula is gliding smoothly. Sometimes where the retinacular fibers are thicker, then I'm just using my non-injecting hand to glide the skin over the cannula and keeping the cannula stationary. So far I've used 0.3, and what I'm going to do now is just augment that mandibular line, and I do this in a very specific fashion. I actually like to pinch either side of where I want my product to go. And then I will actually leave a retrograde linear thread within that restricted area, because I don't want any product to go into the submandibular space. And again, I'm just trying to mask that lower border of the jowl.
Another good tip, if the patient's feeling it, is instead of doing a retrograde injection, do an antegrade injection. So you're injecting your product in small quantities but ahead of you. So you're pre-numbing the area before you've got the cannula into it. That's another really good learning tip for you.
So we have used almost half of the product here. 0.6 is what the aim is. I'm going to put a tiny little bolus in the marionette, but I know that we've got a separate segment on tackling and helping support the perioral region, and we will cross that bridge in that segment. But to all intents and purposes now, we have actually treated this area, and I'm at exactly 0.6, and I will just bring out my cannula. And if we just rotate you a little bit, you'll hopefully be able to appreciate the fact that we've brought that segment out into the light. Now, as mentioned in another segment about light and light reflectivity, we had confluence going from the forehead to the temple to the cheek to create this beautiful C shape around the eye, because we know beauty lies in light. What we've done is effectively just supported the lower face area as well, and just highlighted the great skeletal features that Millie has, and just started to mask those early signs of aging. But otherwise, that is a nice result, and hopefully Millie should be pleased with that.
So now we're moving on to complete Millie's perioral area. And for me, this technique I'm going to show you today really is something that's underutilized. We get in overfilled lips and a white mustache, a white shelf, and I'm sure we all can recognize those. And our patients are rejecting having that dissolved. The product is redistributed into the cutaneous lip. When we use this technique, we can soften that white lip, that white roll, by injecting into the subcutaneous layer in the cutaneous lip. This has two results. It reduces the barcodes or the perioral rhytids, or what we call the smoker's lines, and it increases the loss of volume that the patient has undergone during the aging process. And I think if Millie blows a kiss now, you can see that there's a deficiency that while Kam has done a really beautiful job on the lips, there's now a deficiency just in this cutaneous lip. And this can be tackled in a multi-layered technique. So with RHA1, because of its dynamism, because of its rheology to match the biology of that tissue plane, we're going to go in and subcise the retinacular cutis that are creating these smoker's lines, perioral rhytids, release those, put a small amount of product, and then over the top of it, if needs be, I'll flat blanch in the skin with, again, the same product. And while I'm here, I can actually go down into the marionette area and just elevate this corner of the mouth from above. So from one entry port, I'm hoping to be able to augment the lip and turn the corner of the lower commissure in a more positive direction. So again, I'm just going to lean the patient away. I'm going to choose a point where I can actually get access down into the lower lip as well. We know the vessels here are superficial, so I'm going to just lose the bevel. And with a primed cannula, we're going to get into the superficial plane. And you can see again how superficial I am. And the beauty here of having a cannula that's got some rigidity to it is I can just subcise through these retinacular cutis, releasing these, creating some wound healing, which in itself will add some new fibroblastic activity in the area. Releasing this fiber, there's a fibrofatty layer where the skin is now attached to the muscle. And you can see if you're in the right tissue plane, there will be resistance. If it's just gliding, you're too deep. So as a learning point, this might look an easy technique, but you have to look really quite superficial. If you're deep, you're going to end up in the muscle. And then I'm going to retrograde a small amount of product into this area.
This can be a little bit uncomfortable, again, partly because of the subcision. Therefore, using some topical anesthetic is kind to the patient. The anesthetic in the product, 0.3%, will give some relief. However, it can be quite uncomfortable. So that's a nice thing to do. What do you think about that, Jeremy?
I agree. I think this is one of the more painful areas of the face to do. And because you're quite superficial here.
What if it starts looking a little bit lumpy, Jeremy? Any worries about that?
Well, I've chosen the product deliberately here. You know, the rheology of RHA1, as you know, Kam, it is so forgiving, I can just massage it away. And now I'm going to get Millie to open her mouth wide, and it creates some traction. And from this point, I'm just going to release the SMAS, and I'm going to come down the side of the mouth here. And now look, I am down into that marionette. I really think that this is a very powerful approach to turning the corner up. And even with the smallest amount of product, you can create an elevation in this area. I can help Kam and augment Kam's marionette with this technique as well, because I'm right down here and I can reduce that shadow. And there, just from that one point, you can see now that there's a significant elevation in that corner.
And it's another way of multi-layering, isn't it? Because I replaced the slightly deeper volume loss using a product that is more volumizing, and then you've gone over the top of that and we've returned to the multi-layering technique or sandwich technique.
It's not. It's multi-layering, far more sophisticated.
It is, but hey.
So blow us a kiss, and again you can see that the volume has been restored perfectly. I'll do the same on the other side. I'm not even sure that we need to flat blanch over the top of that.
No, I can bear witness to that. Pout for us again, please, Millie. No need at all. I think we've got one line here. Let's see how that fares after you've augmented that to see if she needs flat blanching.
But for me, again, we've improved the contour of that cutaneous lip. What we don't want to have is convexity of that top lip. What we're trying to achieve is still a concavity, but a supported concavity that still is obeys all the anatomical boundaries of the cutaneous lip.
We're now looking at neck augmentation and rejuvenation for Millie. If we have a closer look at Millie, she's been very diligent with her skincare and has protected her neck. Therefore, we're not seeing significant signs of aging in the neck. What we do see, though, is if you just lower your chin for us a little bit, please, Millie, is some of the beginnings of those pesky necklace lines. So the approach we're going to use here is a multi-layering approach, whereby I will use a cannula. I'll use a 25 gauge 50ml cannula and use Redensity 1 to actually help redensify the skin and give some nutrients to that extracellular matrix and hydrate that very fragile skin of the neck. And the aim for me is to be above the platysma and ideally in the deep dermis or just below. And then what Jeremy will do thereafter is actually chase the lines themselves using RHA1, which is a little bit more robust, and use the 4mm 30 gauge needle to flat blanch into that line, which will then give us a great combination treatment in softening the necklace lines, but also supporting the skin and the skin health. Okay. Small pinch. Literally just burying the bevel, and I'm pulling the skin up and away from any of the deeper structures there. And then here we have my cannula prepared. If you just turn slightly away from me, please, Millie. Thank you. So my cannula has just sunk underneath the skin, and you will see that I'm actually just manipulating and molding that skin around the cannula, and I will just lay down a small layer of product retrograde. And as you can see, I've just elevated that domed tip of the TSK Steroglide cannula to navigate itself through the retinacular fibers that do connect platysma to the skin. And this enables me to just smoothly glide back and forth. And I'm effectively doing a radial retrograde linear thread technique and depositing the product across one half of the neck. And then what I will do is, in a similar fashion, do the same thing on the other side. As you can see, once you're in the right plane, the skin and the cannula just glide quite effortlessly with almost next to no friction. So if there are any areas that are more crepey, it's usually the central third of the neck. And this is why I'm just depositing a little bit more product there. And the thing about Redensity 1, because it's non-cross-linked, it often does just fly out of your cannula or your needle. Therefore, you need to be conscious of the pressure that you're putting on the cannula to effectively control the product flow. So with that, I've put in half a syringe of Redensity 1 and half a mil, and I will hand over to Jeremy now to flat blanch the lines, but immediately you'll be able to see that they have softened even further.
It's very nice, Kam. One of the learning outcomes for you guys at home was how superficial Kam was throughout that. You've got a product that's uncross-linked, and so you've got to be really close to the surface. I'm coming in now with a product, the next one up in the product, in the toolkit, and I'm just going to go superficially and try and get into this line in the flat blanching technique. It's very important here that you don't put too much product in, otherwise you'll end up with the product showing. So I'm just losing the bevel. I'm super flat. Look how flat my entry is. And I'm just going underneath, perpendicular to the line, to create a small elevation here. The amount of product is minimal in this line. If you end up putting too much in, you'll end up regretting it and having almost another necklace.
I mean, that is coming up very, very nicely. And Millie, just to tell us how comfortable or uncomfortable is this?
Very comfortable. I don't hear anything.
Okay. And I know she's not lying because I can see her carotid pulse in her neck. So I know she's not lying because she's definitely not tachycardic.
Absolutely not. I feel very relaxed.
So with just a small amount of product there, and this is a great product with this needle, you can do the whole face with some flat blanching. You can start at the forehead and work down. If you go in at 45 degrees with a 4 mil needle, you've gone in at the depth of 2 mil. That's just geometry. That's just maths. And what we know if we want to stay safe is we need those boundaries in place. So when I'm coming in at this angle and just losing the tip, I am so superficial. I've got to be practically in the epidermis, dermis. I'm really close to the surface. So I need a minuscule amount of product here to get the outcome.
Perfect. The other thing, just to make sure that your patient is aware of, is because the skin of the neck is relatively thin and delicate, and they are at a slightly increased risk of having a little bit of bleeding or bruising. So just make sure they plan ahead for that. But otherwise, well done, Jeremy. Good result.